Okay, so George, are you going to be host?
Betsy, are you concerned that the captioner is not here yet?
Yeah. I have a phone number. Let me call maybe Aiello.
Okay.
Let's see.
Good morning. For those of you who just joined us, we will be starting in a few minutes. But just to remind you, we are streaming live on YouTube and this meeting is being recorded. Good morning. For those of you who've just joined us, we will be getting started momentarily. Just to remind you that we are streaming live to YouTube and this meeting is being recorded. Good morning. Just give folks one more minute to join, but in the meantime, just to remind you that this meeting is being recorded and we are live streaming to YouTube.
Good morning.
Morning, George. Lori's here.
Hi, Lori.
Morning, George. It's Rick.
Good morning, Rick. Lori, are you the one that says owner?
Yes.
Okay, I'm going to change that.
Good. Is that something that's hardwired in my computer or? Oh, there it is. Okay.
No.
Everyone.
Okay, we'll go ahead and get started. I have some housekeeping announcements first, and then I'll do a roll call just for attendance, and then I will turn it over to our chair, Laura Bowser, to get the meeting started. Due to the active state of emergency, this is an electronic meeting pursuant to item 4-0.01 of the 2020 Appropriation Act. This is the second quarter meeting of the Alzheimer's Disease and Related Disorders Commission. A meeting notice has been provided. The meeting is being recorded and minutes are being taken. All votes will be conducted by a roll call of voting members. Meeting materials are posted under the Alzheimer's Disease and Related Disorders Commission's quarterly meeting tab at the link posted on this slide. Let me just advance the slide. Public comment, members of the public are able to live stream this meeting via the DAR's YouTube page. Please be advised that if the live stream is interrupted, we will need to pause the meeting until it is restored. Public comment will be accepted by email or phone to my attention. Public comments that were received by December 7th, 2020 will be read or, if lengthy, summarized during the meeting when we reach that agenda item. Most of you are, I'm sure, are familiar with Zoom by now, but just to quickly walk you through the functions. Members, please keep your microphone on mute unless you're speaking, as this helps reduce background noise. Also, before you speak, please state your name. Not only does this help your colleagues on the commission know who's talking, but it also helps Cecily with documenting the minutes. This is particularly important as committee members will be discussing recommendations, and our captioner will be trying to caption the discussion. Members and guests, if you have your video enabled, please be aware the system may capture your image and video in the public streaming and recording. Please only use the chat feature if you have a technical issue or other issue not related to the business of this meeting. Chat comments are not captured in the live stream or the recording, so are not available to members of the public. You may also use reactions to do a thumbs up for agreement or a clap to raise your hand to speak, although again, this feature should not be used in place of a verbal vote in a roll call vote, as it's not captured. If you would like to view the real-time captioning of today's meeting, please click the CC button on the menu bar at the bottom and select Show Subtitles. Zoom participants will be able to turn on closed captioning. The YouTube streaming will automatically include the captioning. View options are on the right-hand side of your screen. You can set those yourself, although some features might be set by us. For all votes, we will do a roll call, and you will be asked to indicate your support with an aye or a yes, your opposition with a nay or a no, or abstention. Lastly, I would like to thank the DARS video teleconferencing team and the DARS communication team for making this electronic meeting possible. I'll do a roll call to confirm attendance. Laura Bowser.
Present.
Travonia Brown Hughes.
Present.
Karen Darner.
Present.
Chris Desimone.
Present.
Karen Garner.
Present.
Rick Jackson.
Here.
Karam Khan.
Yeah.
Kim Kuttner.
Present.
Carol Manning.
Present.
Lori Filippo.
Present.
Lena Sargent.
Present.
Margie Shaver.
Present.
Crystal Thompson.
Present.
Pam Teester.
Present.
Ishan Williams.
Present.
Thank you, everybody. Laura, we do have a quorum. In fact, everybody is here. So I'll turn it over to you now.
Thank you, George, and welcome everyone. It's always weird having these virtually, but it does make for great attendance. So I hope you're staying well. I know it's weird that this is our final meeting in 2020. Hopefully we'll be able to meet in person next year. So we always like to start with just a brief introduction of who we are and what brought us or led us to be on the commission. And so I'll go ahead and start, and then George, I'll let you kind of walk through and just roll call individuals, and then we'll go ahead and get started. So as George mentioned, I'm Laura Bowser. I am chair of the commission. I've been on the commission, I believe, about 6.5 years now. Pulled me to doing this work and sort of supporting Alzheimer's research as my mother passed away from early onset Alzheimer's in 2017. And I have been an active volunteer and on the board of the Alzheimer's Association here in Richmond for about 3 years now. All right, George, you want to go ahead and call on next? I think you're muted.
Thank you, Laura. I'll just go alphabetically through the members, and then I'll ask guests to introduce themselves. So Travonia Brown Hughes.
Good morning, everyone. My name is Travonia Brown Hughes. I'm assistant professor at Hampton University. I'm very new to the commission, but it's an honor to be here and an honor to serve. My background is in gerontology. Actually, I got my PhD from the University of Kentucky, where it was an honor and a joy to be at the University of Kentucky with Dr. Pam Teester, and she was actually one of my instructors. So again, just an honor and a joy to be here. I've done quite a bit of work in community-based research, particularly looking at cognitive aging in African-American populations and minority populations. So again, an honor and a joy to be here. Thank you.
Thank you. Karen Darner.
Hi, I'm Karen Darner, and I live in Arlington, Virginia. I've been a speech therapist in the public schools. I retired 10 years ago, and but I got involved with the Alzheimer's Commission about 2.5 years ago, and as a result of my mom, and she had vascular dementia, and I was with her when right after I retired until her death in 20. And then my brother, who just turned 72, was diagnosed with a form of dementia and was one of the COVID-19 victims in April of 20. And I have really felt very strongly about the lobbying efforts that we have with our members of Congress in the House and the Senate, and that has really been an extraordinary experience, especially with the last couple of years, with the increase in research funding that's come about. We keep our fingers crossed for the next batch, but that has made a in what kinds of things are occurring for those who are diagnosed or those who will be diagnosed in the future. Thanks.
Thank you, Karen. Chris Dessamhead.
I'm Chris. I'm an estate planning and elder law attorney. I live in Roanoke. We have offices down here in Smith Mountain Lake, Roanoke, Blacksburg, Botetourt. So I deal with this on a professional level. I've been with the Alzheimer's Association about 15 or 20 years. And I was thinking, and that's enough about me. I was thinking, by the way, what a great job Laura Bowser has been doing. This must be so difficult to lead a group in this pandemic. Here we are doing Zoom meetings, communication's tough. So Laura, you're doing a great job. This has got to be incredibly difficult to lead us in this kind of time. But anyway, I'm down in Southwest Virginia. Thanks.
Thank you.
Thanks, Chris, and I will echo you. Laura, you are doing a fantastic job. Karen Garner.
Yeah, hi everybody. I'm Karen, and I do echo what Chris said. Thank you so much, Laura, for stepping up to the plate, because there were so many volunteers in that meeting to take over. I am now in Richmond. Those of you that have known me for a while on the board, I was in Newport News, and recently I moved to the Richmond area. So when we are able to meet face to face, I'll definitely be a lot closer. I came to the Alzheimer's Commission several years ago after my husband passed away from younger onset Alzheimer's. So glad to be here.
Thank you, Karen. Rick Jackson.
Good morning, everybody. I'm Rick Jackson. I think this is my 4th year on the commission. I live in Williamsburg. I've been managing hospital-based and community-based programs for older adults for more than 25 years, most recently at the Riverside Center for Excellence in Aging. And like many of you, I have personal experience in it, as my mother had Lewy body dementia, and happy to be here, happy to serve.
Thank you, Rick. Karam Khan.
Hi, morning everybody, afternoon, morning everybody. So my name is Karam Khan. I'm based out of the Northern Virginia. I live near the Herndon area. I'm mostly kind of a misfit, because my primary job is more into the IT field, but I also have a small home care company which I run in the Northern Virginia area. That's all about me. Thank you so much.
Thank you. Kim Kuttner.
Hi, good morning. I'm with the Riverside Center for Excellence in Aging and Lifelong Health, and that's in Williamsburg, Virginia. And my journey started with my grandfather living with Alzheimer's and wanting to make changes. So now it is fantastic to be a part of this really solution-based work group. Thank you.
Thank you, Kim. Carol Manning.
Good morning. I'm Carol Manning. I am director of the Memory Disorders Clinic at the University of Virginia, and I had 2 grandparents with dementia.
I am very happy to be here, and thanks for all of what all of you do, including George. Thank you, George.
Thanks, Carol. Lori Filippo.
Yeah, my name is Lori Filippo. I live here in Richmond. I'm a licensed OT, and I have a master's in public health, which is coming in very handy right now, from the University of Michigan, where back in the 70s, there was a public health program in health gerontology. And that's how I really became involved in the gero part of OT. I came here to teach at VCU, and I also taught at the University of Illinois, but most of my career was at Circle Center Adult Day Services. I was there for 35 years, and of course, we served many, many people with dementia. I would go back a bit. The first person I ever worked with who had dementia was back in 1970 at a big public state psychiatric facility in Michigan, which was the best we knew to do at that time. So I'm in my second year on the commission, or second term, I should say, motivated by both of my parents. My dad had vascular dementia, my mother with a more classic Alzheimer's. Healthy as everything, and into her 90s, but with severe dementia.
Thank you, Lori. Lana Sargent.
Hello, everyone. It's good to see you all. It's nice to see faces. I am vice chair, I think less than a year now, but I'm honored to be serving on the commission. I'm really motivated by both personal and professional factors that bring me here to serve the Commonwealth. I'm a clinical provider at VCU in geriatrics, and so many of my patients have a lot of aging syndromes that we see, including cognitive impairment, all the way to Alzheimer's and related diseases. And then my research also, is focused in early detection and prediction of Alzheimer's. So if we can find factors that we can detect early, may help us determine not only treatment effects, but early intervention. So that's been a big focus for me. Interesting enough, a lot more of my work has been turning towards vascular dementia, just because of the population I work with has a higher risk for vascular dementia than classic Alzheimer's. So anyway, I'm happy to be here with you all, especially nice to see faces during COVID, feeling isolated, certainly at home with my two kids.
Thank you, Lana. Margie Shaver.
Good morning, everybody. I'm Margie Shaver. My professional background is in marketing. My personal connection is my mom, my grandmother, and 3 aunts all passed away with Alzheimer's. I'm a former board member with the Central and Western Virginia chapter. I've been an ambassador for the chapter and an advocate for, gosh, probably close to 20 years. And I'm very honored to be here.
Thank you, Margie. Crystal Thompson.
Good morning, everyone. I echo, it is great to see people's faces. I am held captive with 2 dogs and an occasional young adult daughter if they grace me with their presence. So I've been on the board or on the commission since June. I've spent my career in human services administration at Commonwealth Catholic Charities, brain injury services, and most recently at family preservation. My interest is personal. My father was diagnosed about 2 years ago with Alzheimer's, and his mother actually died in her early 40s from early onset dementia. So I have an intrigue and interest, especially in absorbing all that I can. So thank you. I'm very happy to be a part of this group from Southwest Virginia, Roanoke area.
Great. Thank you, Crystal. Pam Teester.
Good morning. I'm so pleased to be in the midst of all of you and I agree, see faces, and I know it is a very challenging thing to have to run any kind of meeting and show up for one too, actually, and be somewhat coherent. I am very I'm a researcher and a theorist and an ethicist, having to do with issues of surrogate decision-making, abuse, end-of-life decision-making. That's really where I come to it. I know that my dad had MCI, but I don't really have any family members up to my knowledge that have had a relationship with Alzheimer's, but I think I'm a pretty ardent advocate for the rights of individuals, not an attorney like Chris, but I work with them. And I've done a lot of work in exploitation and self-neglect, but human rights and supportive decision-making and a whole lot of stuff like that. So I'm working on the next book I'm working on right now is called The Worldwide Face of Elder Abuse, and Often Dementia makes people vulnerable for that, as we know. Anyway, thank you very much. It's really great to be in everybody's company. And Trey, I still can't get over getting to see you. So that's so nice.
No.
Thank you, Pam. Ishan Williams.
Hi, everybody. Thank you all for being here, and thank you all for your work and leadership on this commission. I'm one of the newbies as well. I just started this year and happy to be here. I am an associate professor at the University of Virginia. My home department is in nursing, but my actual PhD is in human development and family studies. And so I do a lot of research with older adults and their family caregivers who take care of them when they have memory loss or chronic conditions in conjunction with memory loss. I also do a lot of work in community engagement work. So Travonia and I are starting to do some work together on community engagement, working with hard to reach, or not really hard to reach, but underrepresented populations in research and clinical trials with dementia. So, and happy to be here.
Great, thank you, Ishan. And guest, Carter Harrison.
So I'm Carter Harrison. I have been the Director of Government Affairs for the Alzheimer's Association here in Virginia for 18 years. I have recently been promoted. I will now take on a role with the Home Office where I help educate government affairs staff across the country and serve as a mentor for many of them as we do more staff development on a national level. For those of you that are perhaps a little concerned about the upcoming General Assembly session, I am here for the duration of the General Assembly. So I will be covering that role as they are currently seeking a new person for the Director of Government Affairs for Virginia.
Great.
Congratulations.
Congratulations on your
Congratulations.
new role.
It's well deserved.
Attaboy, Carter.
Certainly. I know we're glad that you'll still be here for the General Assembly, but we wish you great success in your new role. Marcia Dubois.
Good morning. I'm Marcia Dubois. Congratulations, Carter. I am the Deputy Commissioner for the Division for Community Living. And my personal connection with Alzheimer's is that I have had an aunt and a stepfather who lived with Alzheimer's and also passed away. So I was a caregiver for both of them. And so this commission is near and dear to my heart, and I really appreciate all the work that you all do in your service on this commission. So thank you.
Thank you, Marcia. Kathy Miller.
Good morning. I'm Kathy Miller. I'm the Director of Aging Programs and Services at DARS. I'm also a Master's Prepared Nurse, and I have my personal connection was I had a father-in-law and a grandmother with dementia. So this topic is also very dear to me, and I do appreciate that you serve as volunteers on this commission and all the work that you do. So thank you.
Thank you, Kathy. And I'm George Worthington. I'm the Dementia Services Coordinator with the Department for Aging and Rehabilitative Services and staff to the Commission. And I also want to acknowledge Cecily Slacer, our Administrative Assistant, who is busy taking the minutes for this meeting. So thank you. And did I miss any guests? Okay, I think not. So Laura, I'll turn it back to you. Thank you.
Yeah, and congratulations, Carter. That's awesome. Although you should have led with you'll be here for the assembly and then told us the news. Thank you. So as usual, we want to start with the meeting with a reminder of why we're here today. And so I'm going to read briefly the Virginia Code for the role of the Alzheimer's Disease and Related Disorders Commission. And that is 1, to examine the needs of persons living with Alzheimer's disease and related disorders, as well as the needs of their caregivers in ways that state government can most effectively and efficiently assist in meeting those needs. 2, develop and promote strategies to encourage brain health and reduce cognitive decline. 3, advise the governor and General Assembly on policy, funding, regulatory, and other issues related to persons suffering from Alzheimer's disease and related disorders and their caregivers. 4, develop the Commonwealth's plan for meeting the needs of patients with Alzheimer's disease and related disorders and their caregivers and advocate for such plan. And 5, establish priorities for programs among state agencies related to Alzheimer's disease and related disorders and criteria to evaluate these programs. And with that, I will go ahead and move that we look at the agenda and approve the agenda for this meeting. So at this time, we do need to approve. It's just part of the process. Does anyone have anything they'd like to add to the agenda, or is there a motion to approve?
So moved.
Yes, moved.
This is Rick.
Great.
This is Pam, second.
And George, do you want to go ahead and do a roll call?
Yes. Laura Bowser,
Yay.
Travonia Brown Hughes,
Yay.
Karen Darner,
Yay.
Chris Dessimone,
Yes. Yay.
Karen Garner,
Yay.
Rick Jackson,
Yay.
Karam Khan,
Yeah.
Kim Kuttner,
Yay.
Carol Manning,
Yay.
Lori Filippo,
Yay.
Lena Sargent,
Yay.
Margie Shaver,
Yay.
Crystal Thompson,
Yeah.
Pam Teester,
Yes.
Sean Williams.
Yes.
That's a unanimous votes with off the agenda. Thank you.
Thank you all. And now we need to review and go ahead and approve the minutes. We do not have to take a vote for this, but has everyone had a chance to look over the September 8th minutes and review? Are there any corrections to these minutes? And George, I don't know if you have them.
Can you see them on the screen?
Yes.
Okay. So I'll just scroll through them much too quickly to read them, but
If there are no corrections to the minutes, then the minutes are adopted as presented. Okay, and then moving quickly, I do want to open up the floor to public comment. The way this works is things are emailed to George in advance. George, did you receive anything in advance of this meeting?
I did not, Laura.
Okay. Then we will move on now to the Division for Community Living report with Marcia Dubois.
Good morning again. So I wanted to start off with just recognizing a few new faces that we have in the division, and start off with letting you all know that we have a new lifespan respite voucher coordinator, and she comes to us as a Virginia Tech grad. Her name is Liza White. And we are going to be sending out some announcements this month, and George can push those out to you all. Just reminding you about the Lifespan Respite Voucher Grant Program. I know you all have heard about this before, But we do want to get the word out. The program still exists. It is vouchers for $400. And we realize that's just a drop in the bucket for caregivers, but it is something. And so you'll be hearing from Liza about that program soon, and George will get that information out to you. But we're very excited to have a little extra help. That position has been vacant, and Nick Slintz has been doing the work of 2 people now for quite some time. So we're thrilled to have some extra help on board. We also have a social work intern who's working under our grand driver director, Nancy Lowe. And her name is Renisha Dennis, and she's just been fantastic. She's been getting experience helping out in all of the programs, and she's been a great help. So if you see her name on anything, she is a social work intern, and we have her a little longer than we thought. So she should be with us through the spring, and we're really excited to have her. Also on board, we have Catherine Mcdonald, our new No Wrong Door project specialist. And she, in this new role, will be instrumental in supporting the implementation of key projects for Virginia's No Wrong Door program, including implementation of the COVID-19 relief grant, the launch of the person-centered portal, also developing guidance documentation for virtual person-centered options counseling services, as well as engagement for aligning aging and disability services, and our new partnership with VATS, or Virginia Assistive Technology. In addition to that, she'll also be a key team member on Virginia No Wrong Doors team developing a social health connector online tool as part of the new ACL's mental health challenge for combating social isolation. So that's a lot, and I'll tell you a little bit about that program in just a minute. Catherine brings a wealth of experience and knowledge to DARS. She's a gerontologist based in Richmond, who previously served as the director of the Longevity Project. And for those of you who haven't heard of that, that was formerly called the Greater Richmond Age Wave. So she's just got a wealth of experience, and we're happy to have her on board. But I mentioned the mental health challenge for combating social isolation. And I just wanted to give a huge shout out to our No Wrong Door program for being one of 2 national winners of the first phase of the mental health challenge that ACL, or the Administration for Community Living, put out. And of national applicants, and I believe there were nearly 40, our No Wrong Door program was selected as one of just 2 that got through the first phase, and won a prize of $75,000. The finalists will be announced within the next month. And so we're very, very excited about this. And their social connector project is really unique. They partnered with VCU's Department of Gerontology, with Virginia Navigator, and with Andrew Kim to develop this social connector. And we're really excited about their possibility for winning. So a big shout out to them. And there's more cash prizes, hopefully, that they might have a chance to win. So stay tuned. We'll know in the next month. And we're very hopeful that they have good chances there. So in other good news, or sharing stories about good work going on out there, wanted to tell you a little bit about our Promising Practices series. And what that is we really wanted to showcase the work that our area agencies on aging have been doing in the pandemic. As you may be aware, they have done just a remarkable job in responding to the crisis almost immediately, not only shifting from congregate settings, making sure that people had home delivered meals, but also really addressing a lot of the social isolation and the anxiety that resulted from the pandemic, and just making sure that people were safe, that individuals had the information they needed to be safe, knew where they could get food, had the in-home services that they needed to avoid having to go to a more congregate or nursing facility setting, and have been just remarkably resilient and creative and innovative in their responses throughout this time. And what we felt like we could do to really help them is we gathered their stories of what they were doing and shared them not only with leaders, with the governor's office, through social media campaigns, but also with federal administrators to make sure that we were really letting them know about how our area agencies on aging were doing more with less. And so we compiled the stories of the work that they were doing in 2 volumes of just really compelling stories. And the 3rd volume that we just published in the last month really focused on a little bit more of the, where we go from here, how the pandemic has changed all of us in kind of rethinking about our technology, how this has been a longer term thing, what policies have had to be changed, how we get to people who are in remote rural areas that may not have broadband, what needs to happen differently. So the 3rd volume is really focused a little bit more in some of the creative ways that the area agencies on aging have managed that. And I really want to commend Kathy Miller and her team who have developed surveys that we started very early on to get an idea of what was the AAA's capacity for meals. Did they have enough food vendors? Did they need more food vendors? Did they have enough PPE? What was it that they needed? And we tried to make the surveys very easy. We knew that they were overwhelmed, but we also knew that they wanted a quick mechanism for being able to communicate with us. And so we did kind of a survey monkey methodology with them that they could communicate with us quickly, and also give some narrative information so we could follow up and capture their stories that way about what they were doing, kind of boots on the ground. And it's worked very well. We do these routine stories, we capture the information, and then we synthesize it into these volumes of what we call promising practices. And so George will send out these links to you. And I hope that you'll have a chance to read them in your spare time. I know that you're all busy, but I know that they'll bring some smiles to your faces about kind of just the resilience and creativity going on in our Commonwealth here, because there's really some great work going on. So that's enough of what I'll say. He'll share the links with you, and I'll just end it there and hand it back to Laura. Thank you.
Thank you so much. And I look forward to reading that. It sounds really inspiring. And now I want to go ahead and move over to the Dementia Service Coordinator report with George.
Thanks, Laura. So you all have a copy of this. I'm not going to share my screen, but I'll just highlight a few of the things that I've been doing over the past 3 months since we last met. So as probably many folks are during the pandemic, I have attended a lot of webinars and virtual conferences, which is a really great opportunity to attend things that I probably wouldn't be able to otherwise. So I just want to highlight a few of the webinars. The National Alzheimer's Disease Resource Center has continued its excellent series of webinars highlighting projects by their grant partners. And I want to give a shout out to both our Virginia ACL grantees, Riverside Center for Excellence in Aging and Lifelong Health, and Carol Manning's University of Virginia's Memory and Aging Care Clinic. Both Carol Manning and Christy Jensen from SEAL have or are about to present webinars on their projects. So that's great. It's great to see your fantastic work being highlighted that way. I also want to give a shout out to the Virginia Governor's Council on Conference on Aging webinars. So in lieu of the conference this year, they've been doing a series of webinars every second or third Tuesday, I guess third Tuesday. Pam Teester, our Pam Teester has been in a couple of those. They've been great. The next one will be next Tuesday, December 15th, on well-being at work, addressing stress as a caregiver or a healthcare professional. And if you're interested in seeing the recorded webinars or joining that one live, which I highly recommend, you can find information on vgcoa.com. So that's Virginia Governor's Council on Aging.com, VGCOA. There have been lots of webinars tackling social isolation, which is no surprise during this period of generalized social isolation, and quite a few conferences addressing that as well. The Alzheimer's Association Greater Richmond had its virtual conference in September. Hampton University had its annual Alzheimer's conference in October virtually, and the Northern Virginia Dementia Care Conference was held over an entire week in November. So those were all very informative and interesting, and many of them have been recorded and are available for viewing. I presented just a couple of times over the last couple of months at one of the Alzheimer's Association's Memory Care University webinar on faith, family, and dementia with my colleagues at Virginia Department of Health and volunteers from the Alzheimer's Association. So that was a great opportunity. I was pleased to be part of that. Also did a guest lecturer for a Master of Social Work class at Christopher Newport University. They were using the Virginia Dementia State Plan as an example of interagency collaboration, which I was very pleased to hear. So that class is taught by Katie McDonough, who's the program manager at the Alzheimer's Chapter Southeastern Virginia. And she had assigned the Dementia State Plan to her students as a good example of interagency collaboration. I think we have about 15 agencies named in the plan, perhaps more. And it was a good opportunity to share our thoughts, but also to hear what ideas these students had. It was an interesting session. I did a dementia awareness for first responders for the Virginia State Police Academy shortly after our last meeting. There were 50 participants in a huge gym. It was actually an in-person session, the only in-person thing I think I've done this entire year, well, since March. I really enjoyed doing that. It's great to see the state police wanting this training, and they had combined two cohorts because of the pandemic, which is why there were so many folks there. I've done a couple of Dementia Friends Champions training sessions virtually. The last one was in September. It was a little disappointing. We've had good attendance up till then, but we only had seven people, but we're trying to do at least one a quarter together. So I do it together with Leading Age Virginia. And our next one's scheduled for January. Coming up as well, let's see. Well, they're all things that were postponed from earlier in the year. So we're still waiting to hear on a few things like the Governor's Conference on Aging. So I'll keep you posted as we learn more about that next year. In terms of data, so I'm going to be giving a little update on the BRFIS data later in this meeting, so I won't address that here, but there's been no updates to the CMS data, which is typically our best granular data on numbers of people living with dementia at a county level, and that has not been updated since 2017 is the latest available. In terms of collaboration and partnerships, so I've attended a number of meetings for things that I'm part of, such as the Virginia Caregiver Coalition, Riverside grants, Riverside's SEALS ACL grant program advisory council, and I was also able to sit in on the medication review committee meeting in September, which they've added a pharmacist to the team. I think we've heard some about this already in the commission meetings, but that's one that they're really pushing hard to sustain into the future. Let's see. Virtual meetings on national level, Raise Family Caregiver Council, and also the Advisory Council on Alzheimer's Research, Care, and Services, the National Plan Advisory Council. Always very interesting. Lots of new things going on in the caregiving space. So as I learn more interesting things, I will definitely bring them to the commission. And I think that's about it on that. And just an update on the two grants. So the Virginia Center on Aging GTE grant that we have for supporting the Dealing with Dementia program in many areas of the state. So that grant winds up at the end of this month. We did receive a 6-month no-cost extension because it was originally due to end in June, but due to the pandemic, they allowed 6-month no-cost extensions. We had hoped that by this point we'd be able to start delivering those workshops in person, but obviously we haven't been able to. There is a virtual option that was developed in August or released in August, but unfortunately, most of the trainers have found it difficult to recruit people, so there have only been 5 workshops. We had hoped to have at least 20 by the end of December. But the good news is that the Rosalind Carter Institute, which supports the Dealing with Dementia program for caregivers, has extended everybody's registration through September next year, by which time we would certainly hope to be able to do the in-person sessions. And we still obviously have the resources to provide those workshops to nearly 800 caregivers at no cost. And then the other grant is, of course, the CDC's Bold Public Health Programs to Address Alzheimer's Disease and Related Dementias grant received by the Virginia Department of Health. We've had a couple of initial meetings between the key partners, so that would be the Health Department, DARS, and the Alzheimer's Association. And I will keep you posted as as the plans gel more. At this point, we're just revising the work plan. CDC felt we were being quite ambitious given the situation on the ground this year. So we have wound back things like the number of pilot sites for specific projects, and hopefully we'll be able to achieve those. So I will keep you posted as we move forward. And I don't believe there's been anything new on the policy and legislation front, but if I'm wrong, I'm sure Carter will have an update on that. So thank you.
Thank you, George. You've been very busy, and we just appreciate all that you've been putting in, especially given the remote working and just kind of craziness of this year. And I know that we have a really packed agenda, but I would love to hear the feedback from that student session on the roadmap, because I'm sure that was really interesting. So with that, we're going to move into the work group and committee reports. The one good thing about the situation of everything being electronic and Zoom meetings is it has made it a lot easier for our work groups to sort of get momentum going and to meet regularly. And I've been privy to all those conversations. I've been attending all the work groups, and it's been wonderful to hear all the ideas and work that you all are putting into just the commission as a whole. And so with that, I want to turn over to the first work group that we have on the agenda, and that's the training work group, and it's chaired by Rick Jackson. So with that, I'll turn it over to you, Rick.
Thank you, Laura. Good morning, everybody. You should have in the packet you got from George notes. So I will, I'll speak about those notes. I first want to say that we just have a very skilled and a very dedicated group of people on this committee, to include Kim and George and Laura, and there's community members that we've recruited to serve on this committee who are current practitioners providing these kinds of services. So it really is an honor to lead the group. And what you're going to see when you look at the notes is that we met in November, and we began to discuss packaging materials that we believe would be important for a primary care workforce, that we would envision this would be used statewide. And in that package, we obviously looked at screening tools. You know, what are primary care practitioners using? We look at training materials, and we looked at ways to make referrals and also to follow individuals who've been screened and referred. One of the things we talked about was a unified brand for products, and you're going to hear George talk about that later. You know, that we have branding that's consistent and easily recognizable, so that anyone who sees it across the state will know where it came from. Then we jumped into screening tools and what we knew about screening tools, whether it be the MOCA or the MiniCog, the SLUMS, the AD8, and everybody on that committee talked about their own personal experiences with using them, and both their limitations and the wonderful things about them, so that we could move toward recommending one or two of them, obviously based on who they're serving and where they're being served. In regards to outreach, we started talking about a brochure. Obviously, to the extent we develop recommendations about training or screening or references, how we get that word out is going to be vitally important. And so how are we going to distribute it? What is it going to look like? Is it going to be easily digestible and concise so that people can see it, not chuck it, but understand that they can move through it pretty quickly? So we started talking about a brochure that would go through those various things that we're looking at. And obviously we want to refer to the Dementia State Plan. As you heard George say, he was very encouraged that people are using it as examples of collaboration and how we develop missions and vision about how we're going to serve the folks in the state. We also talked about ways to encourage workforce engagement, and many of you have had experience with motivational interviewing. So we talked about motivational interviewing and how that becomes an important component to provide training to practitioners so they can be more successful in helping people determine their next steps in dealing with Alzheimer's and related dementias. And, you know, but we were also very sensitive to what a day is like for a practitioner or a primary care provider, and how many people they see, and how limited amount of time they have to provide the services they provide. So we started talking about what we know about microlearning. And if you've watched presentations on microlearning, you know that they're small, they're digestible, they often come in 8 to 10 components, and that they're perpetually available. You know, they can be accessed at any time during the day and night. So we talked about how microlearning can in fact increase the chances that as we go through these recommendations that primary care practitioners and other practitioners are in fact going to find them easy to use. And if we don't tackle that, and if we aren't successful at that, we're just not going to be successful in our overall goals. And then, of course, we started talking about the BOLD grant. And as George will describe later, we have a chance to look at pilot sites throughout the state. So we begin to talk about where those pilot sites might be. And we talked about geography, urban versus rural. We talked about the access to clinics and geriatricians. And so we'll be looking at that very hard, making some recommendations as we move forward. And then early in 2021, the training group will meet again to discuss what kind of progress we've made on all of these goals. And I went through a lot of it pretty quickly, Kim. So Kim or Laura, George, if I've left out anything that you want to add to it, please do.
Good summary. Thank you, Rick.
Thank you.
Yeah, thank you. I think that covers it. And I know that Rick, that George is going to go into some of the branding a little bit later. So I think we can kind of circle back around the conversation then. Thank you. And I guess now let's move on to the coordinated care work group with Karim Khan.
Hey, so we've been focusing on adopting the Washington State Roadmap for Dementia for Virginia. We met on November 2nd. And as Laura mentioned, it's much easier to get these work groups done on Zoom because of our, geographical how geographically dispersed we are. So we took the Virginia's BOLD Act Public Health Programs grant submission is included in the funding to print 5,000 copies of the finished product and a 12-month work plan. We discussed about the roadmap, not covered in June, what the sections that we had not covered in June. So we took this opportunity to do that, including a completely new section with specific information for caregivers themselves, such as the importance of self-care. We discussed branding, marketing, and training around the roadmap. We suggested using artwork of people living with dementia, right? And rather than, just nature and things like that. We've approved this suggestion, and we're gonna work on this. We suggested ensuring the titles include people living with dementia because, the original was a guide for family and care partners. We believe that the Virginians impacted by dementia. So the new title which we are planning is Dementia Roadmap, a guide for Virginians impacted by dementia. We will have a draft ready by early 2021. We hope to meet in January in 2021. And the final product should be approved by the Commission in June of 2021. And we are well in track to get that done. So if there's any questions, let me know, or we can move on to the next work group.
Thank you. I think you covered it. It's been really, we're definitely on track, and it's been fun just kind of working through page by page and trying to make it a little bit more warm so that people look at the materials and don't feel like the disease is what they're labeled as. So no, I think you've covered it. So yeah, then let's move on to our final work group. Lana is the head of our data and research work group, and I'll turn it over to Lana.
So I just want to echo the sentiments said previously about being able to do this in a virtual environment and how engaged we all can be with that. We've got a great group. For our work group, there were two goals under the state plan that really started our discussion off. One was the 5C2, which is aimed at lifting participation in research of people from underserved communities in research. And the second was increasing the number of projects aimed at better serving underserved communities. So big aims, but started off right away in our first meeting, coming up with an idea about how we can connect researchers and our community. And one of the ideas was that we've been working on in the last 2 meetings that we've had is really creating a space, a functional space for research to report to the community and community to report back to researchers. So an environment or a space in which that discussion can happen, and also an opportunity for research to reach out to communities that may otherwise not have access or know that it's going on. And so that's in general the big concept idea. And the last meeting we've been working on operationalizing that. So how do we do that? And very similar to what was said by Rick Jackson, we've actually been talking about sort of flash presentations in the same way, thinking about how we can do this both synchronous, virtually, but also asynchronously so that we can be more inclusive. The presentations would be given both by researchers, but caregivers, people who've been a part of research. So an opportunity and a space where these flash presentations can be given by a wide variety of people who would represent different views of participating in research, possibly even doing research, and the opportunities that are out there. And then we also talked about, that would be an asynchronous method, and then also using a synchronous method where we have an opportunity to gather everyone together in one space to provide some discussions around how do we connect researchers. And there was an emphasis on not only certainly in reaching people and engaging them in research, but also having researchers give back what they've learned. So if they have, finished a research project and have engaged, to also report out what they learned back to the public in this space. We talked a lot about what these flash presentations might look like and how we might be able to provide a template for people to follow. And so we also talked about branding in that case too. So I think there's a good thread there that all the work groups could use. We talked about sort of a 5-minute pre-recorded segments that are delivered by research, individuals impacted by dementia, and all of us also service providers. So really sort of touching upon all groups in that asynchronous method. And I'm thankful to Pam Teester, Pamela Teester, who's going to connect with me. Her and I are working on connecting now. We're going to do a mock-up flash presentation as a way to sort of start thinking about how we would operationalize this process and potentially what content might be in there for each individual who would be a part of that process. We're also talking a bit about the platform, what platform could potentially be used to give access to individuals or make this accessible to the Commonwealth. And also the second part of that is, once it is out there, what data do we want to collect for it that's going to be useful, not only to our group to receive feedback and improve what we have, but also tracking data from this, as well as information that we might be able to collect for the commission. So I think that sort of, you have the list that from the report that we put together. Again, that's the general idea of what we're trying to achieve operationally. I think we're now moving into the operational phases of it. So how do we actually implement the asynchronous and potentially synchronous methods? And I'll open it up to any other. We do also have recruited people outside the commission to engage in conversation with us. So that's been really very helpful in getting to think through this process. But I'll open it up to other members, a part of the work group, to make sure that I haven't missed anything and that I've represented the group well. And then secondly, open it up to the group members for thoughts.
This is Carol. You did a great job. Thanks.
Thank you.
Agree.
Thanks, everyone.
I agree, Lana.
Margie agrees too.
Well, thank you. I'm excited to see your and Pam's mock-up. I think it's there's so many different ways that this could go, and it's been really fun just hearing all the different.
So are we.
So that's actually all 3 work groups. I'll go ahead and open up. Does anyone have any questions for the work groups? I know that we went through a lot of information, but I'll just open it up for a second for questions. Okay.
I had just a brief question for Rick. You spoke about administering cognitive screening tools, and I just wanted to know, did you all run across any tools that could be administered online or tools that could be administered via Zoom by chance?
You know, that's a great question. As you know, previous to the pandemic, we always wanted to do these in person. At the clinic at Riverside, we did them in person because there was pen and pencil, and there was the importance of seeing them and observing them in real time. So I don't know that we spoke much about that. George, Kim, do you remember any discussion of doing it virtually or via Zoom?
We didn't really talk about that during the meeting, Rick, but based on things that I've heard through webinars and speaking to other folks, several of these instruments are quite amenable to being done virtually. So yes, I think we'll need to explore exactly which ones can be done effectively in a virtual environment. But yes, it's possible.
Yeah, and I think one of the great things about the group that we have, as I mentioned earlier, at least 2 of those individuals, actually 3, are presently in clinics administering these kinds of, exams. And so as we do our research and we hear something about the success of a virtual exam, we'll have some expertise who want to weigh in on that and say, yes, I think that's a good idea, or no, I don't. So I think we'll bring back an informed, educated recommendation.
So this is Carol, can I add something to that? Speaking as a neuropsychologist, it's important to remember that those are screening tools. They are not diagnostic tools. And yes, we're all gaining lots of experience doing virtual examinations. And one of the there are certain things that are quite amenable. Follow-up visits are quite amenable to virtual telehealth. Initial visits and diagnostic visits, not as much.
Thank you, Carol.
Okay, thank you for that information. The reason I asked is because currently I'm conducting a study in which I have my participants to do an online screen. It's the Cogstate Brief Cognitive Battery. And so I'm looking, and I haven't been too impressed with it. And so I was looking for an online tool that is reliable, that is valid, but one that would allow me to recruit participants from, again, as far as California. Some of my participants who are in the study are from areas outside of Virginia. So again, just to use the tool as a screening device, again, not diagnosing anyone, but it does extend the reach in terms of potential research participants. So again, that's why I was just looking for something else out there.
And that makes sense what you're talking about. And Cogstate is, I share your concerns, but it's really about the same as many of them.
Okay.
Rick, this is Lana. And it's possible that you all have talked about it, but maybe it wasn't mentioned. But one way to engage providers is to offer, CME or CEU credits for their licensure. So when you get to that phase of offering the micro learning, which I love micro learning, it's nice bits. We can only handle so much for shorter periods of time are better conducive for learning and retaining information. So, but one way is to offer or to get them accredited in some way, because that is usually a draw for providers of all levels to want to, log on and do something like that.
Well, thank you all. These are great comments. And I think it's actually a nice segue into our next session, which we're going to be discussing the branding support initiative. So if one of the things you probably heard in each work group is that everyone's discussing branding and having some kind of unified brand and marketing strategy for the various projects that we're working on to achieve, the dementia state plan. And several other states have taken this approach with their dementia programs and services. And I'm going to turn this over to George to have a discussion with the full commission. George has prepared a document I think that you've received that explains the concept. And I'm going to ask him to walk us through it.
Thanks, Laura. Yes, so as we were going through the various projects in the different work groups, it did seem like we were creating or adapting many things that could usefully share a brand to help raise their profile, as well as to raise awareness about the state plan and the commission itself. So yes, you have a short document called Branding Proposal, ADRDC, and DARS Dementia Services Initiatives. So I'll just take you through that quickly. Since the last Dementia State Plan, Dementia State Plan 2020 to 2024, Building a Dementia Capable Virginia, since that was published late last year, the Commission has been working on specific projects aimed at achieving or partially achieving specific recommendations within the plan. So currently, these include projects that are aimed at 3 very different but also related audiences. Consumers or individuals and families affected by Alzheimer's disease and other dementias, providers, service providers, as well as healthcare providers, and also researchers. And currently, as you've just heard from the work group chairs, each work group is working on a project that's specific to one of those audiences, and yet there is quite a bit of overlap between them as well. So I'm suggesting that we bring these projects and some of our existing offerings and products, as well as future products, under a unified brand, which will help promote awareness and visibility of all these different initiatives, and to help raise the profile of the Dementia State Plan. So the model that I was thinking of is the Virginia Department of Health Live Well branding, and they describe Live Well as a flagship brand for the Office of Family Health Services to help Virginia become the healthiest state in the nation. And at present, Live Well brings together fact sheets and promotional materials in areas ranging from oral health to injury prevention. So it's quite a broad scope, quite a broad swath of materials. Since this concept started gelling, I've been using Dementia Capable Virginia as our kind of working title. And I don't want to offer that as a fait accompli, but it's something to consider. And I'll get to that in more detail in a minute. The timeline for the current projects, as you've heard, is really to have each of the work groups wrap up their projects by the end of June next year. For example, the Dementia Roadmap, which the Coordinated Care Work Group is doing, is a deliverable under the BOLD Act for Public Health Programs Grant. And the work plan has that being launched by mid-2021. And the broad rationale, as I've mentioned, is to have a single brand housing all our different products, programs, and services available to Virginians impacted by dementia to increase the visibility of these products, the Commission, DARS's role in the dementia space, and the Dementia State Plan. So on that document that I sent you, you'll see a list of the 3 different target audiences and the various things that we either already have or we're working on. So for example, for consumers or individuals living with dementia or families, we are working on the dementia roadmap. We currently have the tip sheets or fact sheets that we adapted from Alzheimer's Los Angeles. Those are currently available on the Dementia Services website, but again, could come under that unified brand. We have a number of webinars that are currently available on All's Possible. We have the Dealing with Dementia workshops for caregivers that I talked about earlier. And we have the Families Program, which was supported by a former ACL grant that DARS had received. For providers, we have the dementia capability training that I do through either with the AAAs or with various providers around the Commonwealth. The dementia capability for developmental disability support workers that I've been doing that was adapted from another ACL project developed by some folks in New York State. And we have the tools for the primary care providers that Rick's group is working on. So that includes the screening tools, the clinical practice guides, and the micro-learning episodes that have already been created under previous grants, and more that are being created under the current grant. For researchers, the Dementia Research Forum that Lana and her group are working on. And then we do have a number of data sources available on All's Possible, but I'm not sure we can actually brand those, but it might be, the Dementia Capable Virginia data portal or something. So we can certainly explore those things. So I just want to share with you, Rick had mentioned, let's see, what do I want to show you first? So I'm going to show you some examples of other states. So you'll see a theme here. So Dementia Capable Napa County, Dementia Capable Wisconsin, and Dementia Capable Tennessee. Betsy McElfresh, who's our communications person here at DARS, helps me out by doing a search and found that several other states use the Dementia Capable title. So I think there's pluses, and there's probably more pluses than minuses around using Dementia Capable. It is a kind of specific term describing a system as a system that can respond to the needs and concerns of people living with dementia effectively. So that includes a knowledgeable workforce, understanding those needs, being able to refer and provide appropriate services, and follow-up care. So as we know, the Dementia State Plan is a blueprint for a dementia-capable Virginia. So perhaps that would lead into using that name for the brand. I'm also going to show you just some mock-ups that Betsy's done for potential logo for Dementia Capable Virginia. So that's one with the brain. These are very early stages, but just to give an idea of what something might look like, and then Dementia Capable Virginia with the idea behind this was the various lobes of the brain, but it's a little bit hard to turn Virginia into the shape of a brain. So we're testing this exploded Virginia look for a logo. Anyway, so these are just to give you some jumping off points and ideas. And I'm going to show you the mock-up of the brochure that Rick was talking about for primary care providers, just to give you a sense of how this might look in practice. So the logo on this one, Dementia Capable Virginia with a hand. So that's something that I just put together very, very quickly just to have something there. It's terrible. I know I am not a marketing person, so it's considered a placeholder. But the idea behind this brochure would be, you see Dementia Capable Virginia, and then an initiative of the Alzheimer's Disease and Related Disorders Commission and the Virginia Department for Aging and Rehabilitative Services. On the brochure, we have a short description of the state plan and the 5 goals of the plan. And that's something that we probably want to highlight on most of the work that we're doing. We want to tie it into the state plan in some way. And then just a brief description of the Dementia Capable Virginia initiative. This being for primary care workers, we've got 3 buckets of potential things that we can provide them with. So one is under training, one is under resources, and one is under referrals. So the training, we're kind of focusing on the dementia screening and diagnosis. There are some training tools that are available to the public at no cost, so we can certainly provide links to those, as well as the tools themselves. The microlearning lessons that Riverside created a few years ago for the DARS ACL grant. Under resources, we have the Dementia Care Practice Protocol, which is something that we've looked at in the work group, developed by Act on Alzheimer's in Minnesota, and again, available for adaptation. They also have protocols on after a diagnosis and coordinating dementia care. So those can be useful resources for primary care providers, but also wanted to have a little section on why it's important to detect cognitive changes early. One of the things that we hear, particularly for primary care workers, or from primary care workers, is that, or people visiting their primary care doctor with concerns of cognitive decline, is that they may not receive a diagnosis, or they may receive a sort of a diagnosis, but no referrals to guide them into their future care. And we want to make sure that primary care workers actually have something concrete that they can use to guide how they deliver a diagnosis and what referrals they would provide the patients with. So the third bucket is referrals. We want to help connect their patients with appropriate services and supports. So again, the Act on Alzheimer's developed a community organization practice tool that we can include and we can co-brand. The Dementia Roadmap, which the Coordinated Care Work Group is working on, and then just a few key referrals. We don't want to overwhelm folks at this point. It's really about making sure that somebody leaves a primary care appointment where they've discussed their cognitive health with at least these referrals to their local area agency on aging, the Alzheimer's Association, and Virginia Navigator. So, and you can see how the different threads from what the different work groups are working on come together. So here we have the dementia practice, the roadmap highlighted on the materials for the primary care doctors. So, and I think there's some translation as well into what the data and research work group is working on. So that's that gives you a sense, hopefully, of what we're thinking in terms of developing a unified brand. I'd really love to hear what everybody has to think about this. If anybody has some thoughts about the brand name, so whether we want to move forward with Dementia Capable Virginia or whether there's something else seems more appropriate. But I'd love to hear any and all suggestions. Margie, given your background in marketing, I think we'd love to tap your expertise as we move forward with this as well. So,
this is Margie. I like the title, and one of the reasons I do, I think it's clear as to what it means. But I also like it because it dovetails with other states. So if someone has heard of this in Wisconsin, they'll go, oh, we have that in Virginia too. So for that part of it, yeah, I like that a lot.
George, if I could add, as all of you look at the brochure, I'm sure many of you are going to go, wow, there's so much else to say. And there is. And that's one of the things we really struggle with is how are we comprehensive yet concise? How do we cover the waterfront without overwhelming people? So as you look at it and you have suggestions, please think about that dilemma that we were struggling with.
And also, how do we not overwhelm them with the information that there's so much there that someone opens that up and just immediately goes, oh God, that's I'm not going to read all that. And it's gone. Yeah, it's a conundrum.
I think you can do it. I think you can do it by linking. You can keep it short, concise, and then just link, because the kids are going to be doing this. In fact, you got to make sure it's mobile app readable or mobile readable. Really, these brochures might not be physical as much anymore or going forward. So I think you can put all the links you want, Rick, in there, and somebody on a mobile app, like the child, the son or daughter, is going through it, and he just clicks the link and is taken there by Google. I mean, just like anything else. I think you can.
Yeah, that's a great idea. Something that would get their attention and cause clickbait. Is that what they call it on Facebook and places? Clickbait.
What site are you on?
I want to see what this is all about. So it's got to get their attention, and then they can click that. I mean, that's perfect.
Mm-hmm. Mm-hmm.
Yeah, I guess this is Sean. I just had a quick question about whether it was going to be a brochure that was on the website, like on a online, platform versus a foldable, like the way you have it presented. Because I think if you do make it, if it's an electronic brochure, it doesn't have to even be in those 3 columns, because it might make it difficult for people to follow along. So I think that whole arrangement could be changed. But I thought, for what you all included, I thought that was a really good start. Like, this can be the first of multiple sort of in this dementia capable kind of platform rolling out, that we're going to be sending you these, updates about some things that we think are really important for people to know. So I don't think it's overwhelming for what you have in there now. I think it's really good to get started with that. But there may be maybe an area where we can add, what are you looking for? Like, what is there, if there's a way that we can put like a box or some kind of feedback loop to get back to you all to say, like, what are providers really needing? Maybe we've thought about it and that wasn't on this first brochure, but we can include it in the next updated version. So I think some way to include that would be really helpful. But it looks, I love the content that's there right now. I think you all did a great job.
George, from your branding perspective, if you look back at our first state plan, you will see the term dementia capable used in it. It's not in the title, but it does refer to a number of the services. And part of the reason why those were other states have started to use that terminology is because it's spread from from our usage here and incorporated into some of the national priorities for the Alzheimer's Association statewide. So a number of my colleagues in other states have appropriated the term over the years, and it is spread out. So I think it's perfectly a perfectly good way to describe the services that we're talking about as an umbrella. And I'm glad to see that term has spread. I know when we first started using it, I got a lot of questions about what that was. I don't get those questions anymore. So I think that we should, for lack of a better term, ride that horse since we were, helped birth it. So that would be my thoughts for whatever it's worth.
If I could just throw in one more thing, when you were, and I know I'm kind of deep in the weeds and this is all preliminary, but one of the things that struck me with the logo that was of the state of Virginia with the 3 sections, I know that people in Southwest Virginia feel like they're not a part of the rest of the state in a lot of ways and cases. and that by sectioning that thing off, it could just give out a vibe that we wouldn't necessarily want to give out.
This is Pam. I would, being that person, hold on. Being that person in far Southwest, I think I'm farther down than anybody. That is absolutely true. And I would not want to, I would caution against that. I understand a reason for it, but I would caution against it. And also, having been born in the great state of Tennessee, across the line, they too tried the 3 states of Tennessee, and that was kind of a not good way to characterize a state. Yes, it's long. Yes, it's like a ribbon, but it disenfranchises somebody, because I can remember thinking, well, up in Upper East Tennessee, where nobody's heard of Bristol, they surely have heard of Memphis and Nashville. So I'd agree with Margie about that.
By the way, you'll be happy to know, Pam and others, as we're looking at pilot sites, we're taking all of this into consideration. Who has felt underserved, who has felt left out, who's got access to clinics and geriatricians. So I promise you that's being considered.
I'd like to just
thank you.
Add in. Oh, sorry, George, did you want to go first? No. Okay. First of all, I just want to say this is a great discussion. It's nice to see that it's gotten so far that, there's still, that we're almost close to maybe potentially rolling something out like this. It's great. I agree with the sentiments around making this accessible, and potentially, certainly most individuals have apps or have some accessible, some way to do it. A caregiver or care partner has access to one. It reminded me, we created a caregiver app that had a lot of the same components. I completely forgot about it until this was brought up. But so I had worked years ago with a biomedical engineer, a colleague of mine, to create a caregiver app. And we still have the platform. It's available iOS and also for Android. So the platform is there. It contains a lot of the content that you have already put out there. It also includes some screening mechanisms and so forth. So anyway, it's there. If the commission wants to go in that direction, I think we could unearth it and people could take a look at it if you wanted to. And again, the platform has already been created and it's already been supported. So it's already there on iOS and Android. So, and it can be edited, and I'm sure that my colleague who works here at VCU in biomedical engineering would be happy to collaborate with us on it again, if so desired.
That's very exciting. So as listening to everybody's comments, one of the things that I was thinking, I wrote down before a lot of them mentioned that, was having an app to bring all this together. And so I personally think that would be very exciting. And I'd love to at least meet with you and your colleague to discuss that a little bit further before maybe we bring it to the full commission.
It needs some vetting. We started to roll it out and got feedback. It's just like anything else. It needed a lot of attention. But if a group wanted to continue to bring it forward, it has the very foundation there. So
great. And I appreciate everybody's comments about the logos as well. And I know the Eastern Shore feels like that too. So I certainly hear you on the exploded Virginia. So we'll move away from that. And Carter, I did not realize that Dementia Capable was generated from Virginia. So I think absolutely that gives us a very strong reason to use it. And it's I guess probably grown from your original concept. The Administration for Community Living uses Dementia Capable to describe all of its cooperative projects and grants. And it has a 7-point definition of what a dementia capable system is. And that includes pretty much everything that we've been talking about today, as well as the dementia friendly concepts. So I think it's a nice umbrella term to bring everything together.
George, can I add one comment about the logo? I think it really resonated with me, those that had what I'll call the human element in it, that it wasn't geography, it wasn't some symbolic thing, maybe like the brain, which we all understand is at the core of all of it. But all of this is so much about interpersonal relationships and other human things that it would be nice if we had. I thought the Wisconsin one with the silhouettes of a couple of people on the road said more to me than a map or a whatever. So just a thought.
This is Karen Garner, and if we keep in mind Virginia's logo is, Virginia's for lovers and fill in the blank, but there's always hearts there. So following along with what Lori just said, showing that care and compassion and understanding for what people are going through, ultimately that's our goal. So I think something along those lines, even tying it into the Virginia's for Lovers logo, since a lot of people are familiar with that.
Thanks. I like that idea as well. And George, I know we probably need to move on to the next item on the agenda, but I did want to also just mention, don't forget, I think QR codes right now, just given COVID, all the menus and restaurants have moved to QR codes, and that's a really easy way for people to access information. So you might want to leverage that as well. Okay, well, I think, thank you all for your input, and I'm excited about this. I know we've been going back and forth for a while and concerned over what to do with the website. So I think this is going to go a long way to help get us noticed and get the information out. And we'll continue the conversation in the next year. But next is data collection and the 2019 Burfus data. I think it just came in, George, and we kind of discussed it very briefly yesterday. But I think you were even reviewing it up to, I think, right before this meeting. So I'm excited. I wanted you to go ahead and turn it over and kind of walk everyone through it. And then also the conversation that we also had on No Wrong Door. I'd love to just continue that conversation as well.
Okay, thanks, Laura. Yes, so I'll just run you through the Burfus data. So Burfus, the Behavioral Risk Factor Surveillance System. This is the annual health risk survey conducted by every state and DC under the aegis of the CDC. The cognitive decline and caregiver modules are two of the optional modules that states can choose to ask in any given year. We are trying to ask both of those modules on a regular basis. So we asked one or the other in 2011 and 2013, and then we asked both of them in 2015 and then again in 2019. So I'll just take you quickly through the results. The cognitive decline module, the first question is, does the person report increased confusion or memory loss over time? That went from 8.9% of the over 45 population in 2015 to 9.5 in 2019. So it was a slight increase, which suggests the need for more services in the future. The other questions didn't really see much of a change. It was about 35% for people answering yes to that cognitive decline is causing me to give up household activities or chores. About 30% saying that they need assistance with day-to-day activities due to that memory loss. Of the people that said that it had affected them in their day-to-day activities or their household activities, over 80%, so 84.2, down a bit from 87.9 in 2015, said that they were receiving help with, that they needed. We did see a decline in the number of folks who felt that the memory loss was interfering with their work or social activities from 37.8 to 31.9. But that's still, a significant proportion of those folks, because these are people. This is a self-reported subjective cognitive decline. It is not a diagnosis, so if a third of those are saying it's interfering with their work or social activities, that indicates the need for supportive services. What I was a little disappointed in, you can see the graph here at the bottom, discussed with healthcare provider. So the last question that they ask is, have you discussed your concerns, memory concerns, with a healthcare professional? We did see a large increase from 2013 when it was 27.1 to 2015 when it was 51.7, and I had hoped to see another significant increase over the last 4 years, but in fact it stalled. So still only about half of folks who are reporting self-described memory loss are talking to a doctor about that. So I think that's something that we can help address with as we move forward in raising awareness generally, and delivering these specific products and services and trainings. And hopefully the next time we ask this, which would be, we'd aim to do these again in 2023, we'd like to see that number rise. And of course, the BOLD Act grant project is really aimed at incorporating brain health and dementia knowledge into public health messaging, and so that should help increase that as well. Any questions about the cognitive decline module?
Yes, this is Carol George. This I think would be really interesting to write up and publish. Are we allowed to do that? And is there a group that would like to work on it? So I'm not sure whether we can do that. So in the past, the Alzheimer's Association has worked with the CDC to produce state fact sheets on each of these modules, the cognitive decline and caregiving module. I am not sure what the plans are, but I can certainly explore that with the association CDC to see what we're able to do. So you are talking about state data here, correct?
Yes, this is the Virginian one.
So you're not sure who owns the data, is that it?
Carol, the data should be public, George, if I'm not mistaken.
Yeah. So thanks, Carter. So if the data are public, I mean, it seems like we could do something interesting writing about these at least perceived changes within the Commonwealth of Virginia. I don't know if anyone would be interested in working on that, but if they are, I'd be happy to work with a group to publish this, to talk about sort of what this means in terms of trends within the state and what it might mean for the country.
Carol, even though I know my role is changing, if there's a way I can help you with that, I would be interested in so doing. So whether that's committing somebody from my organization or myself directly, I think that's part of the reason why we're trying to collect this data, is to illustrate the exact point that you're talking about.
Okay, so Carter, should we perhaps arrange a meeting? And if anyone else is interested in working on this, George, is it best for them to contact you or to contact me? What works?
Yes, contact me, and then I can act as a conduit.
Great. Okay. And then, I'm sorry, Carter, you and I and whoever else can meet to discuss it. It sounds like someone else was expressing something.
It's Pam. It's a little out of my wheelhouse, but I can wag the dog at the end of the work, just to give you a different sort of approach.
Perfect.
And I'll check with Seal as well and get back to George. Thank you. It's a great idea, Carol and Carter.
I agree. I think it's an important idea. There's been a lot of discussion around the reasons why people may not be reporting some of their symptoms to providers, and just to show it, I think would be really important. We can't, not sure if we can draw any conclusions though necessarily, but maybe there's some additional data that we can get along with this that tells the broader story. But I'd be really interested in.
I think it'd be really powerful if some of the members of the commission all wrote an article together. I think, and presented it somewhere. I think that'd be just way cool.
I agree. And I would encourage people who don't normally do publications to join us. I think everyone offers a view, I think, on the commission. It's unique. Even if you're not necessarily in academia, I would encourage you to join.
Agree. Sometimes it's very refreshing.
I agree. Different perspectives. I agree.
And it would be really great to have it come from the commission.
Agreed.
Or members of the commission, or however we need to frame it.
Yeah.
Like that.
And Carter, who is an honorary member of the commission.
I'd be happy to join as well.
All right, well, it sounds like everybody's on board for that. So yes, if you are interested in joining that group, please email me and I'll send out an invitation anyway, generally, and so we can gauge interest. Just in the interest of time, I'm going to scoot forward through the caregiving module very quickly, and then So the Caregiver Module asks 9 questions. It's really aimed at discovering how many folks are providing care for a family member or a friend.
George, can you zoom in a little bit?
Yep, I'm just
Thank you so much.
Make it a little bit bigger. Okay, there we go. Is that better?
Sean, I thought it was my eyes.
I just didn't know when to interrupt, but that's so much better. Thank you.
Okay.
Yeah, I turned my video off because I'm so close to the screen that. Thank you, George.
You're welcome. Okay, so you can see that the percentage answering yes to providing care over the past month was little change. It was 20.7% in 2015, and in 2019 we saw 20.2%. So about 1 in 5 Virginians providing care to a friend or family member. I am just going to jump right down to number 5, which is what's the main health problem of the person that you're providing care for. And this is really interesting. So we went from, dementia and other cognitive impairment disorders saw 7.5% in 2015 and jumped to 23.9% in 2019. So I'm not sure if that reflects a greater awareness of dementia and Alzheimer's disease, or whether there's more diagnoses being given, or what. So I've asked the health department if they have any insights onto it, but I haven't heard back yet because this was all yesterday. But you'll see there was a big decline in the other category from 57.6% in 2015 to 24.5% in 2019. And this is and so that seems to have gone mostly into dementia and heart disease. So if I learn anything more about that, I will let you all know. The other thing that is important was the duration of care. So you can see from the little pie graph on the side that over half of caregivers have been providing care for more than 2 years, and more than about a third have been providing care for more than 5 years. So it's a long road for caregivers generally. And then people who answer no to question number 1 are asked question number 9, which is, do you expect to care for a friend or family member in the next 2 years? So that's another 15.5% in 2015 and 14.4%. So another 1 in 6 people are expecting to provide care within the next 2 years. So obviously a substantial portion of Virginians. So any quick questions about that? Okay. And the last thing I want to show you is just very quickly, I've been working with a working group from various AAAs, Area Agencies on Aging, to develop a little protocol for better identifying people with cognitive decline or impairment coming into contact with No Wrong Door. So we've developed this little flow chart. We will be rolling it out as a pilot to, I think, 6 or 8 AAAs in 2021. Once I think we're going to need to wait until the vaccine has been distributed and the attention has turned a little bit away from the pandemic, and the AAAs have a bit more bandwidth to take this on. But this would be a set of screening questions asked during a regular intake. So this is not in your meeting materials, but I can certainly share this with you. But it also provides not only that protocol, but also resources and referrals for people living with dementia. Yeah, so I can send that out to folks in their follow-up materials for the meeting. Any questions or comments about those? No? Okay, so I'll turn it back to you, Laura.
All right. Thank you, George. And when you do hear back about any additional data, will you email that to us? I think that would be helpful because that is a very large jump. All right. And George, do you think we have time for the next session, or do we want to start it and roll it over into the next session? Oh, you're muted.
You're muted.
All right. Yes, let's go ahead and start. Travonia, I've made you a co-host, so you should be able to share your screen.
Okay, excellent. And I know that we're running out of time, so I'll be brief. Good morning, everyone. Again, glad to see you all. In October, Hampton University hosted its 3rd Alzheimer's conference in partnership with VCU, with funding provided by HRSA. The original conference was scheduled for March the 26th, and as you know, everything fell apart on the beginning of March because of COVID, and we kept moving the date up, and finally it was decided that we would hold a virtual conference in October, and it went really well. We had over 400 people to register for the conference. We held 3 lunch and learn sessions that featured Dr. Goldie Bird from Wake Forest, Dr. Fayron Epps from Emory, and Dr. Hamid Akravi, a geriatric physician at Eastern Virginia Medical School. And Dr. Akravi spoke about clinical drug trials and some of the latest advances in Alzheimer's research that I thought were very exciting. And I wanted to share briefly part of his presentation with you. So without further ado, I will move in that direction. All right. And everyone can see my screen? Excellent.
The Alzheimer's disease drug development pipeline from 2002 to 2012. I warn you, it's kind of a little bit depressing, but just bear with me. So from 2002 to 2012, we only had 1,413 Alzheimer's disease clinical trials. That's very low considering really the impact that we have because of Alzheimer's. So there were 244 unique compounds. And of course, some of the studies use the same compound or maybe at different, phases of trial. 124 in phase 1, and those are safety trials. 206 phase 2 efficacy trials, and 83 in phase 3 pre-approval trials, pre-FDA approval trials. 36% were symptomatic agents, and 53% disease-modifying agents. 1% we don't really know the mechanism. If you take a look at these 413 trials, overall success rate was 0.4%. 99.6% failure. That's quite disappointing. If you take a look at all the FDA-approved medications from 1990 to 2017, almost 30 years, only 4 medications approved for Alzheimer's disease, and these are only symptomatic treatments. So now, the reason for that, we think, was just because those clinical trials that they were performed, they were mainly at the stage of dementia, and maybe a stage of dementia is too late. So for that reason, there is some rationale for prevention trials. because there were 13 large phase 3 trial failures at the stage of Alzheimer's disease dementia over the past decade. And these are quite huge trials with over $150 million funding, which is quite spectacular. So now maybe intervention prior to dementia stage, which is really irreversible brain cell loss, may have better chance of changing clinical course or trajectory. And by the way, delaying dementia by 5 years would reduce the projected Medicare costs by nearly 50%. Because what happens if we can delay that, people may actually go out there and just, hit by, let's say, truck, or maybe just die while dancing out there. And that's what we want to happen. Just have a, kind of happy life and, high quality of life. So for that reason, it could be nearly 50% reduction in the cost. Now, think about what happens in cancer, stroke, HIV, diabetes, if we wait to treat until after symptoms appear. Think about cancer. If we wait until people develop widespread disease, that's quite too late. That's not really treatment, that's palliative care. So for that reason, maybe we should really move a little bit earlier in the trajectory or spectrum that I just showed you. Now, with that said, I'm going to just tell you about a few studies. And so from now on, hopefully this would be a positive note and some glimmer of hope. So there is a medicine called aducanumab, and this was actually developed late 2000s. And here in this study, which was in transgenic mice, and these are mice that are destined to develop Alzheimer's disease. On the right-hand figure, you see the aducanumab molecule in colored, and then you can see the amyloid protein there. So you see that how it actually sticks to the amyloid protein, and the brain will clean it up when the aducanumab sticks to the amyloid protein or amyloid plaque. In the middle panel, what you see is the brain slide of those transgenic mice stained for amyloid deposition, and you can see the amyloid deposition in red. On the left-hand panel, you can see how aducanumab attacked those very amyloid imaging protein plaques in the brain. So you can see that it has a very high affinity to the amyloid plaques. So very good medicine in animal studies. Let's take a look at human studies. So then in 2012, Biogen started a phase 1b anti-amyloid antibody, the aducanumab trial. So they actually recruited 166 subjects with mild cognitive impairment or mild Alzheimer's dementia. Age was 50 to 90, and they all had positive amyloid deposition in the brain. And so essentially that was measured by amyloid imaging. They had 4 different doses given every 4 weeks by infusion for 52 weeks for 1 year. So the measurements were at baseline, week 0, and then 26, midlife, and then 52 at the end of the study. So they imaged again with amyloid imaging, so to check for amyloid burden, and they had some memory tests as well. Here's actually the result. So on the top panel, the amyloid burden panel, I want you to concentrate on week 54, which is the right-hand side bars. So here, what I circled here in red, you can see the placebo, and you can see the amyloid protein in the brain or amyloid plaque in the brain. There was really no change, maybe a little bit more positivity, versus the highest dose, 10 milligram dose, significant reduction in the amount of amyloid deposition in the brain. That was about 60%, 65% conversion to amyloid negative. That's quite huge. On the lower panel, you see the memory tests. The one on the left is a test that the lower the better. So in blue, that line in blue, that's people who are on medication, versus in orange or yellow, people who are on placebo. And you can see that they did better. People who are on medicine, they did better. The second one on the right-hand side is the MMSE, and the higher the better. And as you can see, the blue line is higher than the orange line. So essentially, aducanumab, by way of reducing the amyloid plaques in the brain did what it was supposed to do. But of course, it was phase 1B. Now, this is looking at the amyloid burden reduction in that phase 1B. If you take a look at, these are two different columns, right? On the left-hand side, you have the baseline, and then on the right-hand side, you have 1 year after treatment. So the first row that I'm kind of showing here, marking around, so you can see that this is a person, for example, on placebo, water injection or sugar injection, you just name it, not the medicine. As you can see, the amyloid deposition in the brain, which is here depicted in red, did not really change because, of course, this patient was not on medicine versus the last row. When you take a look at that row, this patient was on 10 milligram, the highest dose, and you can see on the right-hand side, after 1 year, essentially there's really no amyloid deposition, or maybe a little bit in the brain. So that's how this medicine actually works. So now, again, that was phase 1B. And then after that, Biogen moved to phase 3 clinical trial, again, pre-FDA approval, with 2 studies, Engage and Emerge. So they recruited more than 1,600 people for each of these trials. All of them had amyloid positivity based on PET imaging. They had amyloid plaques in their brain. And they had MMSE of 24 to 30. This is a memory test. What it means that, you know, the memory problem was very mild. They had 360 sites across the world, 20 countries. Study period was 2.3 years. They started in August of 2015. They were supposed to, close in 2022. However, in 2020, after a futility analysis, they decided to stop. Now, let's take a look at the futility analysis. So what happened is they looked at the analysis for patients who completed the study by 12/26/2018, December of 2018. So what they came up with that, the results showed that the 2 studies were unlikely to meet their primary endpoint upon completion. So they decided to stop. However, this analysis took another 3 months. So within that 3 months, people were on medication still. So essentially they stopped giving medications in March of 2019. So then they looked at the larger population because now there are more people who finished the study. And what they found was, the results was totally different. So let's take a look at those results. This is their primary endpoint. See, there are some of the boxes. This is a memory test. What they found here in those people who had the opportunity to complete OTC, it was 23% reduction in the rate of decline. So essentially people who are on medication, their rate of decline slowed down by 23%, and this was statistically significant. Now, this was a primary endpoint. Most of studies have primary endpoint and secondary endpoint, and in order to be able to go before FDA, they need to show positive results in both primary endpoint, most of them. Now, let's take a look at the secondary endpoint. The secondary endpoints, there were 2 memory tests, MMSE and ADAS-Cog. And then the last one, the third one on the bottom, that is a measurement of function. What you hear that I'm circling around is the result. So there was 23% reduction in MMSE. Essentially, they did better in terms of memory tests. The second was the ADAS-Cog. That's another memory test, 25% reduction. And then in function, 46% reduction or slowing down in the rate of functional decline. So they met all different endpoints, both primary and secondary endpoints in this study. Now, this is the amyloid burden in Emerge and Engage. Again, there were 2 different studies. And what you see here, if you take a look at just the Emerge trial, the placebo, that's the amount of amyloid deposition in the brain. Of course, it went a little bit higher. And then when you take a look at the green line, which is the high dose, you can see the reduction in the amount of amyloid deposition in the brain. So essentially 65% of people who were amyloid positive, they became negative. So again, very strong medication. So now, Where do we stand right now? The results showed up to 65% conversion in amyloid positivity, 23% reduction in memory loss, 46% reduction in functional decline. So the status right now, as of today, Biogen has proceeded with regulatory filing before FDA for drug approval, believe it or not. And the plan is for FDA to respond or make their decision just 3 days after election. So by 11/6, probably we will know, and there is a chance, that we will have the first disease-modifying approved medication for Alzheimer's disease. It's quite actually exciting. Now,
all right. So in lieu of time, I was just going to stop there. The unfortunate part of the presentation or the news that came out of the FDA's meeting was that the drug itself was not approved. And the reason that it wasn't approved was even though they had that positive study, they had another additional study, actually 2 other studies in which the results were different and the outcomes weren't as robust and the outcomes were not as positive. So at this particular moment in time, the FDA is basically saying, hey, we need you all to do some more clinical trials, and we need the outcomes of those clinical trials to mimic or to look like the first trial that was very positive. And so one particular FDA reviewer said, if you conduct a study that's much like, your first study, the outcome should be the same, but they weren't. And so because of that, the FDA said, we can't approve this drug to be used on a wide scale when the outcomes don't match up or when there's so many discrepancies, at least from a statistical perspective. But again, the exciting part is, that they've got really close and the drug itself seems to be very positive. So again, it is exciting news, and hopefully if they do go back and they do an additional clinical trial, they can come up with the evidence that the FDA is looking for.
I have a quick question for Travonia. Who was that again? I missed that. Is he with Biogen? Who was that presenter? So it was one of Biogen's guys.
Yeah, no, Dr. Hamid Akravi. He's actually a geriatric physician in Eastern Virginia Medical School.
Was he on the independent review that the FDA did of it later, or was he not on that panel?
I don't think so. No,
okay.
I don't think he was. Mm-hmm.
So we were a part of that trial, and no, he cannot be on the independent review because he works for Biogen.
Right.
So, and Dr. Manning, did you want to comment in terms of next steps, or do you think that the drug will be eventually approved? Was it a problem with data or data interpretation, or do you think that there could be some very serious discrepancies that led the FDA to not approve it at this time?
And there's $5 or $6 billion riding on your answer.
Oh, there's nothing riding on my answer because nobody cares what my answer is. That's good news. I don't think it's the ultimate answer. I don't think that drug is the ultimate answer. I think, it's one of those, depends on how you look at the data, and maybe it will ultimately get FDA approval, but that ultimately is not the disease modifying answer that we're looking for. That's just my opinion. More trials, the better, because I think we really do need something. And it's, is it somewhat promising? Maybe, but it would be, as you heard, the first analysis, the first futility analysis was completely negative. And it was only when they reanalyzed those data, looking at them differently, that they came up with the reasons to continue the trial.
Okay. All right, well, that's all that I had. If you all would like me to send you the entire presentation in its entirety, because he also covered additional drugs, I have no problems doing that.
Thank you so much. That's really
Thank
fascinating.
you very much.
And I know that George, we've also had people reach out recently from different pharmaceutical companies that want to present on different topics. And I know that we're talking about having some of the work groups look at that because I think it's interesting and things that we need to stay abreast of.
So if I can just say a word on that, because I work a lot doing the various clinical trials, and I think it is really good for us to hear about, but it's important to remember that when you have someone from a pharmaceutical company talking to you, they have a very vested financial interest in it. And so we just need to be aware of that. We want them to do good work, and they are, but they also have a vested interest in their particular drug.
He sounded so sure it was going to be approved.
No.
I completely agree. And George and I actually discussed that. We don't really know what their motive or angle is, but we want to stay aware of the research. And one of the ways that we thought maybe having the work groups listen to it first, kind of vet it and report back versus having it so publicly displayed during the actual commission session.
I think we need to be really careful that we are not doing advertising for the pharmaceutical industry, and that it does not appear that by presenting any of their work that we are endorsing them.
Correct. I agree.
We have, in the time that I've been in my working at UVA, we have gone from having the pharmaceutical industry bringing us lunch and presents every day to they are not allowed in the clinics anymore. And I think that's the much better avenue to go. We need the pharmaceutical industry to do their jobs and to make sure that they try new drugs and can prove them to be valuable, because ultimately that's what we need. But we also need to keep in mind that each company has its own reasons for being successful, and that we need to be objective.
Thank you. Yes, I agree. So with that, I think what's left is actually to discuss the calendar next year. You'll find the 2021 meeting dates listed on your agenda, but they are as follows: March 9th, June 8th, September 14th, and December 14th. And I think that we've already approved that. So is there any new business?
Yes, Karen Garner has some new business.
Yeah, hi, everybody. And thank you again for that information, Travonia and Dr. Manning. That, is right up my interest. So it's good to get different perspectives other than what we're reading about in the news. So anyway, so thank you. But I'm sorry, I need to get my head cleared after that information. So on the drugs. So as far as new news, I would really like to encourage each of you to participate in the Alzheimer's Association upcoming Day on the Hill. It will be January 21st, 2021. Obviously, we're not going to be meeting in person. They have shortened the General Assembly session to 30 calendar days. So it's going to be a mad dash to try to figure out how to communicate with our elected officials. The more voices we have in the shorter time frame, the better our chances are. We are going to once again come back with the dementia case management program. For those of you following, we were able to get that program in the budget last year, but when COVID hit in the spring, the governor cut it from the budget. So we were not able to bring it back during the special session. We were able to keep priority testing in nursing facilities and long-term care facilities, which was very important. And we'll be keeping our eyes on any kind of COVID issues during the session. We will be asking for everyone's support for that. So You will need to register so I can communicate with you updates on how to get in touch with your elected officials and what we would like for you to share with them. So if you haven't already, text the word AIM, that's Alzheimer's Impact Movement, AIM, to the phone number 52886. That word again is AIM, AIM, to the phone number 52886. I did send out last week a registration link through that, and I'll be sending out another one. I also have a link that I can send out by email that I will be sharing with George to send out to the group. I think it's really important during the General Assembly for those elected officials to hear from the Governor's Commission members on not only what we're doing, but why this particular program is so important. And what better voices to have than those experts that are deciding best plans of action for the Commonwealth. So it would be really great to have your participation, either reaching out by emails, social media, letters to the editors, or by phone calls. Obviously, we're not going to be able to do in-person meetings, so any or all of the above are ways that you can reach out to them. So, that being said, that's my update. Yes, Rick.
Laura, you said June 8th, but the document says June 6th. Is it 6 or 8?
Oh, let's see. I'm working off of, George, can you clarify? I think I'm working off of the longer.
This is Sunday, so it's got to be the 8th.
The 8th. Okay.
Yes, it's the 8th. Sorry about that.
Thank you. No problem.
I got a
One
quick
other
new
question.
business item after Rick.
Oh, yeah. One other question. So, George, you know, there is a legislative platform that was developed through the commission, and I take it Carter and you are going to be involved in presenting that to the legislature.
Yes. Well, at least Carter is, yes.
Okay. Thank you.
Yeah, everybody can find that. That was in the annual report that we drafted in September.
Quick new business. This is minor, but administratively, but it'll help new board members. I have a confession, which is I'm not really good with names and faces. It took me like 6 months to figure out who you guys were. Even though we have like name cards at the meetings, we only meet quarterly, and half the name cards I can't see anyway because they're on the same side of the table. So as I was watching this, if like a year and a half from now, the goal is to meet in person again, if that's what the goal is, you ought to do a YouTube screenshot at one of the upcoming meetings when you have all the members, George, or just take out your cell phone and click. And so when you get a new board member, send that to them so they know who everybody is. Because I didn't know who Rick Jackson was. I didn't know he was a celebrity. It took me like a year to figure it out.
That's a great idea, Chris. I'll try and remember that for the next meeting. Thanks.
Thank you all. So if there is no other new business, meeting is adjourned. And I just want to say thanks for spending all the time. I know it's always long when it's on Zoom, and have a really happy holiday, safe holiday.
You too.
Have a nice holiday.
Thank you.
Bye,
And
everyone.
thanks, everybody. Happy holidays.
Bye.
Bye.
Good beginning of 2022.